to make start the session.
Good afternoon, doctors. On behalf of Heathrow, I, Dr. Khande Parkar, welcome you to this webinar on influenza and its management and its prevention. Heathrow Healthcare Doctors, as you know, is an innovative pharmaceutical company. Our journey began in 1993. We have 30 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in our portfolio with 21,000 employees globally. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. And we have Asia's largest manufacturing facility complex at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic, the Heathrow Healthcare, pioneering antiviral, offered products like Fluivir, oseltamivir, favipiravir, and remdesivir, for which they were awarded Award of Pharma Excellence in August 20 for COVID drugs. Today, our webinar is influenza and its prevention. We all know the menace of influenza and how it affects the quality of life and can be threatening and dangerous in children. There are many papers on influenza and its prevention, but to have their experience with us, today we have got Dr. Prashant Chavan and Dr. Nikhil Doke, our own doctors, to share their experience on influenza and its prevention. Dr. Prashant Chavan is MBBS DCH DMP, Fellowship in Pediatric Intensive Care and PGPN from Boston University. Sir is currently Chief Consultant Pediatrician at Chavan Hospital, Vice President at Parvati Charitable Trust, Treasurer Aurangabad Academy of Pediatrics. He has several publications to his credit, just to name a few: carotid intima media thickness and oxidative stress, markers for assessment of atherosclerosis with children with beta thalassemia, poster presentation on experience of bubble CPAP in level 3 NICU in Neocon 2010, absence of diarrhea in birth series of 8 children. Has attended several conferences and workshops like Pediatric Advanced Life Support course, workshop on pediatric critical care, Rainbow Hospital, Hyderabad, CMEs, ICH, Chennai, National Conference, Neocon, Jaipur, and Pedicon. Sir has attended various workshops on ventilator support and intensive care management. Dr. Prashant Chavan has been speaker at National Faculty at Spurs module, National Faculty at ILEAP module, and speaker at various regional and state level conferences. Welcome, Dr. Prashant Chavan. Our next speaker for the day is Dr. Nikhil Doke. Sir is MBBS MD Pediatrics, a life member of Indian Academy of Pediatrics. Has received several awards during his lifetime tenure. For poster presentation first prize, IIPA Mumbai Breastfeeding Week, e-poster presentation, Breastfeeding Promotion Committee quiz winner of IIP PG quiz. Has published paper in adolescent on Nasik, effect of screen time and lifestyle diseases. Dr. Nikhil has conducted guest lectures on Down syndrome at Vikhe Patil Nursing Home, IMNCI workshop, resource person, Department of Child Health Nursing, Vikhe Patil Nursing Home. Advantage of breastfeeding symposium, Vikhe Patil College of Physiotherapy. Has conducted workshop like high disease behavior in adolescent, VPMC Nasik. Dr. Nikhil Doke has teaching experience as assistant professor at Vikhe Patil Medical College and CSMS Medical College from 1st October till date. Welcome, Dr. Nikhil Doke, and I hand over the session to Dr. Prashant Chavan for further deliberations. Welcome, sir.
Thank you, sir.
Thank you, sir. Thank you for such a generous and warm welcome. So now I will share the presentation of today's topic of oseltamivir is empirical use in pediatric population. So our talk will be mostly focused on how to use, what are the guidelines, some of the case studies we will discuss, some of the papers we will discuss. I hope I'm audible. There is no issue in audio video. So
you are audible.
Yes.
Yes.
So empirical use of oseltamivir in flu management. So first we'll start with the rationale behind use of this oseltamivir in pediatric population. So our talk, today's talk will include the healthcare challenges that we face in monsoon and various diseases and how to arrive at diagnosis. Influenza is a major culprit in during monsoon season and winter season. What are the clinical evidences of oseltamivir? What are the guidelines, different national and international guidelines for empirical use of oseltamivir in pediatric population in so-called suspected or proven cases of influenza? So So healthcare challenges, there are so many illnesses which are labeled as influenza-like illness or flu-like illnesses. We have other infection which are affecting similarly on respiratory system like H1N1 and SARI. As per the government of India guidelines, severe acute respiratory illnesses is called as SARI. These are all different range of viruses which are affecting the respiratory system and causing severe and acute different types of illnesses, from the OPD to IPD to severe ARDS type of infection. And now, last since 2019, we have the COVID-19 infection and the COVID-19 virus and its variants we are getting throughout the last 3 to 4 years. So all these are going to cause influenza-like illness or flu-like illnesses, primarily affecting the respiratory system. So this is the one study done in Department of Virology in 2019, King's Institute of Preventive Medicine Research. So they have taken a huge samples of 36,670 specimens, and they are subjected to influenza analysis. The duration of study of very long, 7 years. So the influenza positivity started with the onset of monsoon and peaks during the post-monsoon month. So this is the pattern that we see in southern state of India. So overview, incidence of influenza and related death are increasing alarmingly in India. So you can see from 2015, 18 and 19, the number of death due to the cases which are diagnosed and the deaths here on the right hand side of your screen are the deaths due to the influenza cases, proven cases of influenza, which are alarmingly rising in India all across the India. So what is flu? Flu is one of the most common infection disease caused by influenza virus. It is highly contagious, airborne disease that occurs in a seasonal epidemics and manifests as an acute febrile illness. The illness ranges from the very mild symptom with 1 or 2 days of fever to severe illness up to ARDS and need of ICU or PICU. Serious outcome of flu infection can result in hospitalization and death also, as we have seen in the previous slide. So there are types of influenza viruses depending upon the antigenic drift and antigenic shift. So they changes their antigenic uh, presentation on flu virus, and that's why we need to develop new immunity as per the presentation of virus currently circulating influenza virus. Influenza A causes the frequent epidemics due to minor antigenic variation and periodic pandemics 4 or 5 years down the line. Like we have seen the swine flu, bird flu, all these are pandemics due to major antigenic variation. Influenza B virus infect only humans and causes local epidemics like in southern, northern, or in India only. Such local small epidemics it causes. Influenza C virus infect the human and swines. Influenza type C infection generally causes a mild respiratory illness and not thought to cause the epidemics or pandemics. So currently there are subtypes of H1N1 virus like influenza A virus, and influenza A virus subtype is H3N2 influenza virus, which are currently circulating since last few years. These are the only viruses which are circulating. Then how it is getting transmitted? So it is the air droplet transmission from the coughing, sneezing, secretion of respiratory system. And the virus is very contagious. It can flow up to 6 feet away. If somebody is coughing, sneezing, still he can transmit that virus to that person. So most healthy adults may able to infect other people beginning from the day one before onset of symptom like coryza, sore throat, or fever, and up to 5 to 7 days after becoming sick. And children may pass the virus for longer than 7 days. So this is the variation and transmission depending upon the severity of illness to that patient. So what are the symptomatic differentiation between all these COVID and influenza like illnesses? First is influenza like illness. Fever is there, mileage is all these different presentation. Cough, lack of energy, malaise, sore throat, all these are present in You are all these influenza-like illness, H1N1, RE, and COVID-19. Breathlessness is particularly as you go from the severity of illness, it can present in H1N1, RE, and COVID. Loss of smell, loss of taste, mostly is specific to COVID-19. Diarrhea specific to 19. Headache may be present in all of these variant of SARIs. So, what are some of the few important warning signs that you must know when you are treating the patient of SARI or influenza-like illnesses? So, as we are talking in pediatric population, the fast breathing, trouble breathing, cyanosis, that is bluish coloration of body, not taking feed, not taking breastfeeds, not walking up to or not interacting, dull child, too irritable that he doesn't want to get held by the parents or not comfortable with at any position or any at a, for somebody also. Flu-like symptoms improves but never return with the fever and cough getting worse. Fever with rash. These are the symptoms that if they are present, there are the warning signs. And in infant, not able to take proper breastfeeding, chest indrawing, intercostal retraction, subcostal retraction, all these are symptoms and signs of severity of illness, and you must visit doctor as a consultation. What are the complications of this influenza? Pneumonia, bronchitis, ear infection, otitis media infection. Acute otitis media infection is very common in pediatric population. Post-viral, post-influenza, these are very common. Worsening of our existing disease like asthma, COPD, and in severe cases we may land into the ARDS, or even death of the patient can occur. So management of influenza. So most of the time we have the largely supportive treatment with the bed rest, increased fluid consumption, means plenty of water. We always recommend patient that take lot of water, take rest. Even after medicine, if you are of febrile, you may feel better and you may go around. Pediatric population may start playing, but they will not recover soon. So that's why bed rest, increased fluid consumption, symptomatically painkillers, or sorry, means antipyretics, analgesic, like if needed, sore throat, congestion, we may prescribe. Cough, for cough we can give bronchodilator, mucolytics, cough suppressant. These are can be given. If there is severe myalgia, we can add some NSAIDs if needed. If most of the patient will recover in 3 to 5 days, not 3 days, 3 to 5 days. However, the malaise or weakness may persist for few weeks after the influenza illness. Severe cases may require intravenous hydration and admission and supportive therapy for few days, particularly less than 2 years of age group. Here we need all these things. So now we have one viral proper drug available for which is again acting against influenza A and influenza B virus also. So that is the two types of drugs are available. Neuromerase inhibitor, that is our olcetanavir, that we are going to focus our today's topic on that. This drug is going to block viral neuromerase enzyme, which is critical in releasing virons from the infected host cells. Once they are getting blocked, so then all further cascade of reactions of or spread of this virus gets stops. It is active against influenza A and B. So examples are olcetanavir, zanamivir, adamantase or M2 ion channel blocker. They interfere with the higher hydrogen ion channel activity of influenza type A only virus. They are not active against influenza type B virus. Thus, they are going to block the entry of virus into the host cell. So these are the amantadine and rimantadine are the available. So mostly we are not going to use because we want to get protection against both the influenza and B. Then antiviral therapy with olcetanavir. As we have seen, it is a potent inhibitor of neuromerase enzyme in influenza A and B virus. So it affects the replication and pathogenicity, prevents the further spread, and we have used this virus against avian, swine origin, and H9H2N2 strain of the mutated strain of influenza A and B also, where it is still active against all strains of influenza A and B. So CDC, American Academy of Pediatrics, and FDA all have approved this drug for use in pediatric population more than two weeks of age for treatment till adult age group, and for chemoprophylaxis or prophylaxis they have given the permission more than 3 months of age till your adult age group. So these are the proper doses as per the age group. So roughly to 2.5 to 3.5 per kg is the initial doses up to 15 kg or to 20 kg. Then we have all these doses available. So recommended dose is 5 to 7 days depending upon the severity of illness. Up to 10 days we can extend the treatment. The most important thing that I want to highlight here, the treatment with oseltamivir should be initiated within 48 hours of onset of symptom or a contact person if you are getting contact with that person. If you have household contact, sick patient contact, then you get the maximum benefit when you start drug within 48 hours of onset of symptom. It is not like that if we encounter patient in later time or third, fourth day or fifth day, or even seen sick patient on which is landing in PICU. We got referral from other center and patient is on fifth or sixth day and is most likely clinical picture is history of influenza like illness. Then we can start that drug on day 3, day 4, or day 5 of the illness also, depending upon the severity of the patient. So what are the guidelines are recommending all over India or all over world? What are the guidelines? WHO strongly recommending use of this in oseltamivir as soon as possible. Treatment should be started. Laboratory confirmation of influenza virus is not necessary for initiation of treatment. You must go far behind the cause of your influenza-like illness or SARI. Negative laboratory test for H1N1 does not exclude the diagnosis in all patients. Therefore, early starting empirically is very important and very crucial for the outcome, morbidity and mortality of that patient. If high risk individuals have been exposed to the influenza, consider the presumptive treatment with oseltamivir. So that we know that there are some high risk patients, immunocompromised, premature, preterm babies, asthma, COPD, all these patients where there is high risk and there is history of complication or more likely complication. Then here we can start with the presumptive treatment of oseltamivir. So government of India is also said that empirical therapy includes the neuraminidase inhibitor for treatment of influenza-like illnesses when there is a local circulation or there is a other risk, including the travel history or exposure to animal influenza viruses. Then you can start with the empirical treatment along with your whatever the clinical empirical antibiotic. You can start with the treatment. So CDC as says you can start the this is a very safe drug. As I told you, age group for treatment more than 2 weeks of age is 14 days after your in newborn period also you can start the treatment. For chemoprophylaxis at least 3 months is needed for starting chemoprophylaxis. All these drugs is very safe. There are some minimal few side effects are there that can be you should monitor while giving prescribing this patient. Indian Academy of Pediatrics has given a standard treatment guidelines for influenza in children in 2022. Still, these guidelines are holding for our current presentation. They have also recommended giving this influenza in children. And lastly, we have this paper published by American Academy of Pediatrics for the influenza prevention and control in children 2023 to 2024. In these guidelines, almost all the IAP, Indian Academy of Pediatrics, WHO, CDC, all these are following this paper that is American Academy of Pediatrics recommendation paper. And all these guidelines are similarly applicable in all the other recommendation all over the globe. So what are these recommendation given by this American Academy of Pediatrics? So antiviral medication are an important adjuvant in the control of influenza, but are not a substitute for the influenza vaccination. Providers should promptly identify patients suspected of having influenza for timely initiation of antiviral treatment when indicated and are based on shared decision making between the provider and caregiver to reduce the morbidity and mortality. Now, this statement is saying that even in on OPD patients, if there are some indication of influenza like illnesses, severity, contact history, then on decision for taking decision making, you can discuss with caregiver and you can start influenza antiviral treatment with one-to-one discussion, or presumptive empirical therapy can be started as early as possible. Olsetnavir is a preferred antiviral medication as per the American Academy of Pediatrics and all other guidelines. It is a preferred antiviral medication for patients with influenza A and B because of cumulative experience of this drug in children, relative cost, and ease of administration. So this is the preferred first line of drug for any influenza-like illness. Although base results are observed when child is treated within 48 hours of onset, antiviral therapy should be considered beyond 48 hours in certain cases. Now, if you go to this article, you will see all the high-risk patient categorization. What are the indication when you can start after 48 hours? All these are available in this article and beautifully given in a tabular format. So you can go and read for your reference, further reference in your practice. Further, what are the indication? Antiviral treatment should be offered as early as possible to the following individual, regardless of influenza vaccination status and duration of status. Now, this is American Academy of Pediatrics, where the influenza vaccination rate is up to 50% of the population. In India, we have the very poor penetration of influenza vaccination. So, no need of considering whether patient is immunized or vaccinated with influenza or not. But you need to start with the antiviral treatment in following condition. Any child hospitalized with suspected or confirmed influenza disease, like laboratory investigation we have done, then we can get the confirmation. Any child with severe, complicated, progressive influenza disease, regardless of healthcare setting, ये काफी important है. Inpatient रहो या outpatient रहो. If you have anticipation of severe and complicated or progressive influenza disease, on OPD basis, you can start this drug. Any child with suspected or confirmed influenza disease of any severity, if they are at high risk of influenza complication, regardless of healthcare setting, you should start with the treatment of antiviral drug. Treatment may be considered for following individual in outpatient setting after discussing the benefits and risks with the parents or guardians. जैसे मैंने आपको पहले भी कहा है. Any child with suspected or confirmed influenza disease who is not at high risk of influenza complication, if treatment can be initiated within 4 days of illness. अगर आपको पता है इसको कॉम्प्लिकेशन होने की चांसेस है, मगर अगर मैं ड्रग शुरू करता हूँ तो कॉम्प्लिकेशन बच जाएंगे, you can start. Any child with suspected or confirmed influenza disease whose sibling or house contact are either younger than 6 months or at high risk of influenza complication, then you can start the outpatient setting में भी आप Olsetnavir शुरू कर सकते हैं. Initiation of antiviral therapy should be based on signs and symptoms consistent with influenza infection and epidemiological factors. Provision of antiviral therapy does not require a positive influenza test. So this is very important, particularly in Indian setting where we cannot prescribe every OPD patient that influenza उसकी टेस्ट करके आओ, RT-PCR करके आओ, एंटीजन टेस्ट करके आओ, ये सब करके आओ. We cannot do that. Then in such patients, we need to, as a doctor, we need to take proper decision whether to start empirical treatment with the Olsetnavir on OPD patient or IPD patient. So these are some general article where they have done good study. early oseltamivir treatment with influenza in 1 to 3 years of age. They have got a good conclusive evidence that oseltamivir treatment started within 24 hours of symptom onset provides a substantial benefits to children with influenza infection. ये दो स्टडी है. ये लास्ट वाली जो स्टडी है ओसेल्टामिविर ट्रीटमेंट ऑफ इन्फ्लुएंजा इन चिल्ड्रन टिमोथी की यूके, ये काफी डिटेल एनालिसिस उन्होंने किया है. ऑलमोस्ट 50,000 पेशेंट का उन्होंने किया है. एंड देन एट द एंड they have given that there is a definitive proper if you use early intervention of oseltamivir, you get a good result in a patient with influenza like illness or influenza confirmed case of influenza. Now some of the case presentation of I will case scenarios I want to discuss with you where we can start or we have used the oseltamivir and we got the good results. So there are some case scenarios that I want to present. So this was the OPD patient, 6 years old, male, no significant past or medical history, received standard vaccination including annual influenza vaccination, BMI, fever, cough, fatigue in last 2 days. Recent confirmed cases है कम्युनिटी में फ्लू के, ऐसे हमको पता चला कि यहाँ बहुत सारे लोगों को फ्लू हो रहा है. Vitals, he was stable. Sore throat, mild nasal congestion, no significant respiratory distress. Rapid diagnostic test कर ली, positive for influenza आ गया. Started with oseltamivir as per the dose, age of the dose. Supportive care, hydration, fever के लिए paracetamol रेस्ट दे दी उसको. Day 2 पे significant reduction हो गया fever पे, myalgia पे हो गया, and complete resolution of fever with some residual cough on day 3 to day 4 of illness. Post 6 days of treatment, there is a full recovery and there is patient has resumed the normal activities. And follow up, there was no adverse effects reported in this case. Case presentation 2. Here the 4-year-old female, she is a known case of asthma on inhaled scotic steroid, no prior hospitalization, vaccinated but missed the current year influenza vaccine, high grade fever, persistent cough, and there is some shortness of breath since last 2 to 3 days. Temperature was high grade, respiratory was 35 per minute, which is tachypneic. Heart rate is on higher side. Saturation on room air is borderline 91 to 92. On auscultation, we got the bilateral crackles in lower lung zone, and there was a mild nasal flaring and subcostal or intercostal retraction indicative of respiratory distress onset. So blood investigation was done, leukocytosis, lymphocytic predominance, CRP was mildly elevated, but X-ray shows to a bilateral patchy infiltrate with consistent viral pneumonia, which is clinical. I will show you the X-ray of the patient that there are some patchy infiltrated with some viral pneumonia type of picture. Then the viral, we not only do for only RT-PCR for only influenza, but other respiratory viruses also. Here we got a positive for influenza type 1 virus. And then this was the some of the early picturization, some hyperinflation in asthma patient you can see, some bilateral haziness, patchy infiltrates around middle or lower zones you can see. So which was indicative of influenza-like illness. So management, we have admitted the patient as we have got a diagnosis. So there are chances of secondary bacterial infection. So we have started with oseltamivir, supportive oxygen therapy, paracetamol, self-polarization, nebulization every 6 hourly, IV fluid, expiratory monitoring, and everything. For it took third day to subside the fever. Significant improvement in breathing. Oxygen was tapered to room air. There is complete resolution of respiratory symptom with normal activity level resumed on day 5. Patient was discharged on day 7. So early, even patient is presenting 3-4 days early. Once you encounter patient, you can early start the treatment with oseltamivir and proper other supportive treatment like antibiotics. So what are the important challenges in IPD management? Complicated influenza, particularly high risk patient, or this patient is of a known case of asthma. So this is more likely to have the more severe disease or complicated influenza illnesses or bronchopneumonia due to. So that's why we have started early. So despite delayed presentation on day 3rd, 4th, oseltamivir showed this clinical efficacy, reducing the disease progression. Secondary asthma, exacerbation, influenza, commonly worsen with the pre-existing respiratory disease. So necessary the bronchodilator therapy and continued inhaled corticosteroid therapy. So last presentation I will share here. This is a 10-year-old again female respiratory distress, no recurrent respiratory infection उसको होते हैं, but no diagnosed clinical chronic conditions, no history of influenza vaccination, persistent fever, severe cough, and progressive difficulty in breathing for last 4 days. So temperature is high grade, respirator is very high, 45 per minute, heart rate is also high, room air saturation is below 90, nasal flaring, intercostal retraction, auscultation, diffuse cries, wheezing, all over lung field is present. Patient was alert, but was fatigued due to persisting respiratory disease since last 4 to 5 days. CRP is elevated. ABG sources of mild hypoxia, CO2 retention, pH was borderline, leukocytosis with lymphocytic predominance says to viral type of illness. And there was a positive RT-PCR as we have done biofire and other tests. This was a positive. And here, uh, the now we have started with the case presence of OPD patient, then mild. Now this is patient with diffuse bilateral infiltrate consistent with early changes of ARDS. So if patient lands in ARDS, there are severe complication. So this is early changes of ARDS. So you can see there are whiteouts around central and center to peripheral. आप जब जाओगे तो थोड़ा सा whiteouts आपको दिखेगा. So it is suggestive of early changes of ARDS. So we have shifted patient to high flow nasal oxygenation and escalated to NIV due to worsening of hypoxia. Started with olsetnavir 60 mg twice a daily for 5 days at least. Then fever, IV hydration, IV antibiotics, serial ABGs. Then we were prepared for mechanical ventilation if needed, but there was no need. Empirical antibiotics also started. Nasal bronchodilator, oral drugs of fever and all this started. So persistent tachypnea, O2 requirement, maintain NIV for 60%. Then we have tapered on day 3 to 4 FI to 40%, shifted back to HFNC. Then breathing was normalized, oxygen was discontinued, oral feeding was started, and discharge on with instruction to close follow up and influenza vaccination in next in on day 7 to day 8 of admission. So rapid progression to ARDS is very common if you are not going to give proper treatment, and this early rapid progression was halted with proper starting of olsetnavir on admission and supportive therapy. So on day 4, on initiation to day 4 of symptom likely to prevent further buzzing or respiratory illness. So empirical antibiotics are address given. So role of fertilizer is it as it reduces the further viral replication and spread of and further lung injury. So improved recovery time or allowing early weaning from the respiratory system. All these things are there. Summary: proper diagnosis can and early treatment can prevent the flu complication. As we have seen in last case, patient was going to land up in severe ARDS if we are not going to intervene early. Proper supportive therapy is also important. Empirical use. तो डायग्नोसिस करना है, टेस्ट आएगी फिर हम शुरू करेंगे. नो, empirical if you have all the data available. As we have seen, empirical use of olsetnavir reduces the lower respiratory infection complication, hospitalization, and antibiotic use also. So all WHO, American Thoracic Society, Ministry of Health and Welfare, AAP, IAP, all these are going to recommend empirical use of olsetnavir in cases which are influenza-like illnesses, which have the history of complication, high risk of operation. So I will stop my presentation. I want to thank organizers for giving me this wonderful opportunity to present this my few cents with all dignitaries and delegates. So now I will stop the sharing, and Dr. Nikhil want to give some insight thoughts on this topic. So I will stop the sharing and I will hand over further to the Dr. Nikhil.
Thanks, Dr. Chavan. Thank you very much, sir. Dr.
Am I
Nikhil,
audible, sir?
yes, you are, sir.
Sir, I'm starting the sharing.
Okay.
Sir, my slides are visible, sir.
Yes, sir.
Okay, so today we are going to see the very important topic of pediatric illnesses, that is influenza, and the effectiveness of oseltamivir in the pediatric age group. So here I am presenting the three important cases. All three cases are IPD basis, and we are very good outcome with the oseltamivir in all three cases. So case report first, that is severe influenza with the pneumonia in the 6-year-old child. So the child came to us with the chief complaints of high grade fever, productive cough, and difficulty in breathing and fatigue. On the physical examination, on auscultation, we have crackles in the right lung base, and the respiratory rate of the child is 32 per minute, which was high for the age. And the SpO2 level for this child is around 80 to 85. So we have admitted the patient. We have done the basic investigation like rapid influenza diagnostics test and X-ray test. So rapid influenza diagnostics test came positive for these children, and because of the low SpO2 and high respiratory rate, we have started on the O2 by prongs. So the chest X-ray, which was suggestive of the right lower lobe consolidation. Then we are started with the oseltamivir 45 mg twice a daily for 5 days, and the other supportive treatment like O2 by prongs, then hydration with the normal saline, then antipyretics like injection fibrinil, and the oxygen by O2 by prongs. So the fever resolved by day 3, and we have seen the significant improvement from the day first of the administration of oseltamivir in this patient. So X-ray showed the resolution of consolidation after 7 days. So this is the X-ray which was suggestive of right lobe consolidation. You can see here the right lobe consolidation and bilateral patchy infiltrate. After the 6 to 4 days after initiation the oseltamivir therapy, here is the X-ray after post-treatment. So all this consolidation and bilateral patchy infiltrate resolve. So here we have seen the very good outcome with the oseltamivir by the resolution of the X-ray and clinical improvement in the outcomes, like the fever is resolved within 2 to 3 days, and child is very active and asymptomatic within 3 days of starting the oseltamivir treatment. So here we are discussing again the second case. Here the case is with influenza with the bronchitis. So 4-year-old child came to us with the chief complaints of dry cough, low grade fever, nasal congestion, and wheezing. On physical examination, the child is having mild retractions, respiratory rate is high, 28 per minute, bilateral wheezing. So the child is in respiratory distress. So we have admitted this child in PICU, and the basic investigation like rapid influenza diagnostics test and chest X-ray was done. So rapid influenza diagnostics test came positive for these children, and the X-ray done which have suggestive of diffuse peribronchial markings. So all these features are suggestive of the influenza. So we have started the oseltamivir with 30 mg twice daily for 5 days and other supportive treatment with salbutamol, nebulization, hydration, fever management, and O2 support. The outcome of this case is symptom is improved within 48 hours of administration of oseltamivir, and the X-ray is normalized within 2 to 3 days. So this is a X-ray of the children before starting the oseltamivir treatment, and which will suggest you of the diffuse peribronchial marking bilaterally in right side and left side. And this is the X-ray of the same children, which will show the resolution of this marking and clearing of the bilateral lung field. Again, the third case. So the third case is severe case, which is complicated influenza case with the acute respiratory distress syndrome in the 9-year-old children. So the child 9-year-old came to us with the chief complaints of high grade fever, severe shortness of breath, chest pain, lethargy. On the physical examination, child is having high respiratory rate, that is tachypnea, 40 cycles per minute, and hypoxia. The saturation is very low, 89%, and on auscultation, child is having coarse crackles. And by the investigation, we have done the basic investigation like rapid influenza diagnostic test, which came positive for influenza A, and bilateral in the X-ray test, which is showing bilateral patchy infiltrate. So we have started the treatment of oseltamivir 60 mg twice a daily for 5 days, along with the other symptomatic treatment like bronchodilator, supplemental oxygen, IV fluids, and antibiotics. So outcome of this child, the fever is subsided in third day and oxygen need is reduced by day 4 and X-ray normalized within 2 weeks. So I am showing the X-ray. So the children X-ray before starting the treatment is showing the bilateral patchy infiltrate. So here you can see the both lung field, left and right lung field having bilateral patchy infiltrate, and this is the outcome in the same children after starting the oseltamivir treatment in 1 to 2 weeks. So all these parameters like his saturation is improved, his X-ray become clear, bilateral lung field become clear, his fever are gone, and child is very active in 2 to 3 days. So we have seen very excellent results with the oseltamivir in the child with the influenza. So this is the summary of all my 3 cases. So first thing is we have demonstrated the oseltamivir with a very high clinical outcome in the influenza case. So oseltamivir causes rapid symptom relief. Then second thing is oseltamivir reduce the duration of the illnesses, and oseltamivir causes the resolution of X-ray abnormalities. So key takeaway with my all 3 cases are early initiation of the oseltamivir is crucial as said by our Dr. Prashant sir. Key influenza treatment should be started within 48 hours of initiation of the illnesses. Then only the clinical outcome of that child is good. But you can start the oseltamivir treatment after 3 to 4 hours, 3 to 4 days. That also beneficial in the patients. And also the influenza is effective in managing the influenza associated complication in the children. So here I have discussed the 3 cases with the influenza case in which we have given oseltamivir. But in our day-to-day clinical practice in the OPD, we are prescribing the oseltamivir with azithromycin combination for 5 days. So oseltamivir with azithromycin combination in empirical treatment. This also resolves the influenza-like illnesses within 3 to 5 days. So
Thank you so much.
Here I have discussed my 3 cases.
Thank you so much, Dr. Nikhil.
Thank you, Prashant sir, for giving me such an opportunity to
Thank you.
present all my 3 cases.
Thank you very much. You can stop sharing, sir.
Okay, sir.
I thank both Dr. Prashant Chavan and Dr. Nikhil Doke for these wonderful insights. I'm sure the audience has benefited out of it, especially early use of oseltamivir and the benefits oseltamivir use has given, preventing the further progression of disease is very important in children. Thank you very much, sir. Thank you. It was pleasure meeting you. Pleasure listening to your conference, to your presentation. Lovely case studies. Thank you very much.
Thank you, sir.
Thank you. Thanks, Dr. Prashant, once again.
Thank you, sir. Thank you.
Thank you. Thanks, Dr. Nikhil. God bless.
Thank you, sir.
Thank you, all the field people of Hitro. Thank you, IT team, for your support. Thanks, marketing team, and thanks, Shashidhar. Shashidhar, thank you very much. We can start now.
Sir, thank you very much. Excellent झालं. It was the presentation was excellent. So once again, thank you very much. And we can look forward for more such presentations, sir.
Welcome. Most welcome.
Thank you. Thank you.
Welcome.
Thank you, sir. Good day,
Thanks.
sir. Thank you.
Shashidhar will leave. We'll leave, huh, Shashidhar?
Can I leave, sir?
बोला सर.
एक्झिट करायचं
हा, एक्सेप्ट करायचं. हो
Exit करायचंय ना?
हो, डॉक्टर निखिल पण एक्सेप्ट करा. चालेल.
Okay. Thank you, sir.
थँक्यू व्हेरी मच. थँक्यू.